showed up as severely impaired, lost an average of 88.3 days per year. So next, you look at these methods for getting these data. You do a survey, you send out a questionnaire, you draw a sample usually for interviews, and you look at services utilization for your more rare conditions. And the way psychiatric epidemiology goes is you ask people about their symptoms, you ask them, you combine enough symptoms can give you a diagnosis, but the real criterion for a diagnosis in this mild, moderate, severe terminology is impairment, difficulty functioning. And then you try to validate these things. So in your invitation, it says that 15% of people in Pakistan have mild and moderate, and then it said 1.7 million have severe mental illness, and that translates into another 1%. So there you are at 16%. Are you better off than the United States? Well, let's look at that next. First of all, you have to bear in mind that all of our problems with psychiatric diagnosis come down to the fact that we don't have good biological markers for mental illness. We are where the rest of medicine was a century ago. These days we diagnose diabetes by looking at blood sugar studies. We don't have such studies for schizophrenia. What has been happening is people in the elite group experience illness, but their diagnosis and treatment has generally been kept out of sight until they go public, and overcoming stigma is a really essential part of what has been going on to get more attention to mental health. Our Republican senator from New Mexico, Pete Domenici, had a daughter who had schizophrenia, and his coming out about that and his advocacy resulted in equal insurance coverage for mental illness in the United States, our so-called parity laws. But if you go back to that 46.4%, gosh, that's about 50%. And you want to deny responsibility. So you come up with, actually, this was a couplet from a study I'm going to show you, where a fellow looked at the person in the office next to him and he said, "Our statistics show it's 1 in 2. It can't be me, so it must be you." So we can easily get into the blame game in epidemiology. But the fact is, we all have psychodynamics, ways of relating to other people and problems. We all have psychotic thinking. We know this from the stimulation studies conducted by Penfield. If you don't want to have your skull open and your brain stimulated, you can just think about what you're dreaming about. If you're aware of your dreams, you're aware of your psychotic thinking. So the issue is not, do we have these things? And we are all angry at some level. My anger is like the Weather Channel. I can tune in on storms somewhere. The thing that is hardest to cope with is irrational anger. I would argue we all have, in a neo-Freudian way, a child within us that has irrational hopes and desires, and I can work myself up into self-treatment of my grandiosity by sitting in the ground floor of my brownstone on 93rd Street, listening for the screech of tires at the curb that will indicate that our billionaire Mayor Bloomberg has arrived with a van full of gold bricks that he will be unloading into my office. I wait there day in and day out, and it doesn't happen. I'm getting pretty angry about it. We are, in a more serious way, all here today because we have a certain amount of anger about the lack of community mental health here in Karachi. And the great thing about anger is, don't deny it. Anger turned inward is going to get you depressed and frustrated. Turn it into productive energy. So if you can't do that very well, then indeed you get impaired. And again, for diagnosis, we don't need psychodynamics, we don't need psychotic thinking unless you're overwhelmed by it, in which case you're impaired. We need impairment. Next. So why are these epidemiological data all over the map? In part, the more you look, the more you find. I was just in Manila with a colleague from Laos who had dinner with her country's ambassador, and they were talking about mental health, and the ambassador said, "Well, we only have crazy people in Laos. We don't have any other problems." Well, they talked about people they knew, and clearly there were all sorts of things. So one of the issues is We get increased statistics when we have treatment. Years ago, training director in New York sent me, when I was director of a thing called the Multi-State Information System, one of his residents who was black, who had been told by one of his white supervisors bipolar illness doesn't occur in black people. Because at that point, bipolar illness was the thing to have. We had Ted Turner, who gave $1 billion to pay our UN dues. We had Broadway producers, all sorts of people saying, well, yeah, I have bipolar illness. If you keep it under control, you can be very energetic. The thing to do is to be hypomanic, just avoid the mania. And, but I was sitting on top of a data bank of 750,000 treatment episodes, and I looked by way of diagnosis and race, and I showed that indeed we did have people in the data bank with bipolar illness who were black, and the increase in diagnosis had been going up the same way it had in whites, all related to the introduction of lithium and other mood stabilizers. Parenthetically, he went back and looked at the admission records of St. Elizabeth's Hospital in Washington, D.C., and discovered that in the 1910s, when we had a stigma of black people, an image of black people as being happy-go-lucky and with great rhythm, that bipolar illness was diagnosed 3 times more frequently in blacks being admitted to the hospital than in whites. The other thing that you see that muddies epidemiology is advocacy for disease. Right now, the illness that's increasing in the United States is autism and autistic spectrum disorders, in part because of improved diagnosis and treatment, but also parents seeking treatment. And every once in a while you read a newspaper article saying, gosh, if we add up all of the people who are suffering from all of these illnesses, that's more than the general population. How did we get to have 3 million people suffering from disease when only 2 million people live in this area? But the other thing that is curious is the effects of stress. So the WHO Western Pacific Regional Mental Health Advisor offered us in a brainstorming session the phenomenon of suicide among celebrities in South Korea. That's not an economic challenge, that's a personal challenge. When the Nazi army was advancing across France in 1940, the mental health of people was certainly going down. The psychiatric hospital directors assembled their patients and said, look, you've got to get out of here because they come into psychiatric hospitals and machine gun everybody. So everybody, of course, emptied the hospital. After the war, they did a follow-up study and discovered that most of the people who had been in those hospitals were out in the community doing quite well. There was a huge shortage of manpower, there were jobs aplenty, there was a lot of reconstruction, and there was a great deal of community support. So, in fact, a challenge to society, if the community rallies, can be very important, and that brings me to the importance of community part in mental health. Next. So, here are some cost estimates. These are mostly offsets. Next. Here is the argument for treatment rather than just sustaining costs. As you develop, you've got Social Security, welfare, disability, you've got homelessness and other services, you've got trans-institutionalization as your nursing homes and homeless shelters and all sorts of places fill up. Mental illness tends to be criminalized. This is certainly a phenomenon in the developed countries. So you look at people in arrests and jails. It's argued that in the United States the biggest psychiatric hospital is the Los Angeles County Jail. And you have people at home who are big drains on caregivers and families. Next. You can look at non-dollar costs of premature mortality. That's a study of people in public treatment in the United States showing that people with mental illness don't present physical symptoms in a straightforward way, have difficulty getting health care. That's our national suicide rate, which is certainly one of the target indicators of program efficacy. Next. And inadequate treatment without continuity of care will cost more. So we had a very nice young woman from Buffalo, New York, Kendra Webdale, who was shoved to her death under a subway train in New York City by a fellow named Andrew Goldstein, and Michael Weinrich did a review published in the New York Times Magazine, and he had Andrew Goldstein's treatment record. It was a chart, a set of charts, 30 inches high. $140,000 had been spent in the year previous. If Andrew Goldstein had been in residential treatment, $28,000 a year. he probably would have had a better treatment outcome than